Okay, why don't we go ahead and get started. I'm Randy Frost. I'm a professor of psychology here at Smith College. And this is the OCD Massachusetts lecture series on obsessive compulsive and related disorders. OCD Massachusetts is an affiliate of the International OCD Foundation. And they host lecture series at 3 different locations in Massachusetts, one in Boston, one in Worcester, and one here in Northampton. We've been going now for 2 years or 3 years? This is our 3rd year. And so we have these lectures on the 3rd Tuesday of every month. The lectures are followed by a free support group for people with OCD that is led by Ted Clinton, who's here in the front row. And they run from 8 to 9 in the building next door in Bass Hall. So for anyone who's interested, those are free, and you're certainly welcome to go. All right, so this is the kickoff lecture for this year. And what we've decided to do is to do sort of an introduction to obsessive compulsive and related disorders. The introduction will be tonight's topic. Next month, Denise Egan-Stack will talk about OCD in the classroom. Denise is a therapist. She's got a practice on the Cape. She also worked for a number of years at the OCD Institute in Boston. And she has a specialty working with OCD kids. She's also the president of OCD Massachusetts. In November, Meredith Coles will do a talk on her research on sleep and OCD. There's a lot of new stuff coming out now on the role of insomnia and sleeping problems as they relate to OCD. She's got some really interesting stuff where she has been experimenting with treating people for sleeping problems before entering them into OCD treatment and having some good results on that score. In December, Lisa Coyne will talk about ACT for OCD. ACT is a special kind of cognitive behavior therapy called acceptance and commitment therapy. It's a little bit different than the traditional exposure and response prevention, but there's growing evidence of its efficacy in treating OCD. In January, Lee Schur and Beck Belofsky-Schur will talk about the Buried in Treasures program. This is a program we developed here for the treatment of people with hoarding problems. And we just last night started a Buried in Treasures workshop group at ServiceNet. So it's going to be something that we hope to have going on in town here on a regular basis. In February, I'm going to be talking a little about hoarding and in particular struggles with discarding. And this will be a slightly different kind of talk. I'll focus mostly on a project I'm working on now. Someone who is filming herself in her attempts to get rid of things that are real hard for her to get rid of. And she's very insightful and very articulate in sort of describing what this process has been like for her. So it should be pretty interesting. And then in March, we'll talk about exposure and response prevention. And we'll get into the nuts and bolts about what exposure is like in the treatment of OCD. And we'll probably also talk a little bit about the program we've got running now, where we have student interns helping work with exposures. So far, we're having great luck with that program. In April, we have a really special presenter. We're bringing in Shala Nicely from Atlanta, and her talk is called "Is Fred in the Refrigerator?" Shala is someone who had an OCD problem, pretty serious one, really, in fact, completely debilitating. And she entered treatment, exposure, response prevention, and got better, then went on to get her degree, and now she is a therapist treating folks with OCD. She has just a phenomenal presentation style. I've seen her, she gave the keynote address at the International OCD Foundation conference a few years back. absolutely phenomenal presentation, so we're really lucky to have her here, so that'll be really wonderful. In May, Ted is going to show us a movie, My Kid Is Not Crazy, followed by a discussion about OCD in children. And then in June, our last lecture for the year, we will have an Ask the Experts panel with Denise, myself, Ted, and Alan Siegel. So that's the lineup for the year. We hope you will come. We're really excited about keeping this lecture series going. So hope to see you all at each of these lectures. Tonight I'm going to talk about obsessive compulsive and related disorders. And again, this is going to be an introduction. And it really starts with this whole category of obsessive compulsive and related disorders in the DSM, the Diagnostic and Statistical Manual. OCD was moved around this time by the American Psychiatric Association. It was moved out of the anxiety disorder section, where most of us think it belongs, into its own section called obsessive compulsive and related disorders. And it was grouped together with a couple of other disorders. Hoarding disorder, which is new to the DSM. Body dysmorphic disorder, which is a disorder where people have concerns about their appearance, that there are things that are objectionable about their appearance, things that are way out of whack with their appearance, but they're not quite true. Trichotillomania, or hair pulling, and skin picking or excoriation. These are the disorders that are in this section of the DSM. Tonight, I'm only going to talk about OCD and hoarding disorders. I'm just going to give you the introduction to each of these two and a little bit of the background to get us sort of oriented for where we're going for the rest of the season. The diagnostic criteria for OCD include these four things. First of all, the existence of obsessions and compulsions. We're going to talk more about what that is, what they are in just a minute. There has to be a certain intensity involved in these obsessions and compulsions. They have to cause marked distress, they have to be time-consuming at more than an hour a day, and they have to interfere with a person's function. So these are the kinds of intensity variables that we're interested in when we're trying to determine, are these obsessions and compulsions clinical? Do they meet the diagnostic criteria? Because, truth, we'll talk about this in a little bit, these kinds of experiences are common to everyone, okay? That we all have something that resembles this, and I'll talk about what that is in a minute. There are some exclusion criteria, can't be due to substance abuse or medical condition, or another mental disorder, and we'll talk about a few of those a little bit later to give you a sense of what it's like. All right, so let me back up and talk about the first part of this. What is an obsession? Now, according to DSM, an obsession obsessions are recurrent and persistent thoughts, impulses, or images that are experienced at least at some time during the disturbance as intrusive and inappropriate, and they cause marked anxiety and distress. A couple things are important here. It's not just a thought. It's a thought, an impulse, or an image. Okay? So, good example of what's meant by this. How many of you ever been standing on a balcony and had the thought, what if I jump? Right? Okay, that's an example of an impulse. Okay, and we'll come back to how that relates to OCD in a few minutes. The second, these thoughts, impulses, or images are not simply excessive worries about real life problems. These are things that the person recognizes this doesn't make a lot of sense for the most part. There are attempts to ignore, suppress, or neutralize the obsession. I'm going to focus on this neutralize because we'll come back to talk about neutralizing when we try to understand what this means. And the person recognizes that these thoughts, impulses, or images are a product of their own mind. It's not like I believe that my dog is telling me that I have to do this. Okay, I have to think this. So these are criteria for what is an obsession. And that coming back to what these things are intrusive thoughts, okay, that meet these different qualifications. Now, an intrusive thought is something that somewhere between 80 and 90% of the population experience. That thought, if you have it standing on the balcony and thinking, what if I jump? That's an intrusive thought. It's an intrusive thought that most people have. Most people have these kinds of intrusive thoughts that interrupt ongoing activity. That's what they meant by that being intrusive. They're recognized as having an internal origin, that is, that I do them, it's my thought, and they're difficult to control. Another kind of intrusive thought is that song in your head. You ever get a song in your head and it won't go away? That's an intrusive thought, just in the same vein as the intrusive thoughts that become obsessions. Okay? The difference between an intrusive thought, a normal intrusive thought, and an obsession is that normal intrusive thoughts are less frequent, they're less distressing, they're more acceptable, there's less resistance to them. They're considered meaningless. So I'm standing on this balcony, I think, what if I jump? I have that thought, and I think, well, that's a crazy thought, and what do? I let that thought float away. Person with OCD, the thought sticks. They don't let the thought float away. They try to do something to get rid of the thought. That's a little clue to where we're going with respect to what is OCD, an effort to try to get rid of a thought. They're brief, and there's less concern over control of this thought. Okay? So now what we've got here is an obsession. When something becomes an obsession, it's an intrusive thought that somehow, the content of which is not any different than the content of intrusive thoughts for people who don't have OCD. The difference is the effect that intrusive thought has on the person and the person's reaction to it. Examples of intrusive thoughts that are normal, okay? The impulse to hit or harm someone, being contaminated by something dangerous, unnatural sexual acts, harm coming to family and friends, uncertainty about actions. Did I do that right? Did I lock the door properly, and so forth? The impulse to jump off a platform when the train's coming. These are all intrusive thoughts that are normal, that many, many people have. And they're no different in content than the thoughts of people with OCD. The core features of an obsession, what makes these intrusive thoughts obsessions, they're recurrent and they're persistent. They happen again and again. Now, why they happen again and again? Probably because of the amount of effort we put into trying to get rid of them. If you've ever tried to not think about something, you know what that's like. If you try not to think about something, you can't get yourself not to think about that thing. They have an intrusive quality. That is, they intrude on whatever is going on around you. They are unacceptable and they are unreasonable. There is some subjective resistance to them. There's a sense in which they are uncontrollable. And they are ego dystonic. Now, by ego dystonic, what's meant by that is that they're not me. And for the most part, what we find is that people who are highly religious tend to have obsessions that focus on blasphemous thoughts, that violate that sense of religion. That these are ego dystonic. They're not what this person is. They kind of violate that person's mores somehow, that person's values. The obsessional content that's most frequent, dirt and contamination, harm and injury coming to someone, pathological doubt, symmetry or not just right experiences, so that things don't feel just right, and I've got to do something to make them feel right. Unacceptable sexual activity, scrupulosity or concern about whether I have violated some kind of moral code somehow, or whether I've had a thought that violates my religious beliefs and so forth. And there are some somatic obsessions as well. Beliefs about feelings that I have in the body or something being wrong with my body and so forth. Compulsions are the second part of the DSM, and they are repetitive behaviors or mental acts. And this is important to keep in mind, that compulsions used to be the case that people thought of compulsions as a behavior. Well, compulsions are really more than that. Compulsions are either a behavior or a mental act. If I hear a bad word and I have this obsession, this intrusive thought that unless I do something terrible is going to happen. and I have to count to 10 times in my head. That's a compulsion, but it's a mental compulsion. It's not associated with any behavior I'm doing. It's all in my head. These repetitive behaviors are mental acts the person feels driven to perform in response to the obsession or according to rules that must be rigidly applied. All right? So this compulsion is in response to the obsession. It's an important feature here of OCD. The behaviors or mental acts are aimed at preventing or reducing distress or preventing some dreaded event or situation. However, they aren't connected in any realistic way. So my belief is that unless I turn on and off the light switch 20 times, my son will die. Okay? It's not anything that's realistically connected to that fear, to that intrusive thought, to that obsession. Now, so the key features of compulsion, these repetitive behaviors or mental acts, they're performed to reduce anxiety or prevent a dreaded outcome. There is an urge to perform them, so there's pressure behind them to do this, to engage in this behavior, to get rid of the consequences of the obsession. There's a diminished sense of control, this feeling like I can't keep myself from doing the compulsion. I have to do this, I have to do this. And they are not associated with any kind of pleasure or gratification. Okay, so it's not the case that these things are being done to somehow feel good or experience some kind of rush of any kind. These are done in order to prevent the experience of anxiety, to alleviate the experience of anxiety. The relationship between obsessions and compulsions is here is where we come to the important piece of this for understanding what OCD is about. There is a relationship between obsessions and compulsions. The obsessions elicit anxiety, the compulsions reduce it. Okay? 75 to 91% of OCD patients have both obsessions and compulsions, and most of us who do research in this area believe that it's virtually impossible to have an obsession without a compulsion. That they are so closely tied together, and the failure to find it for some people is because we're not good enough at figuring out what that obsession is, what that compulsion is. You can see what the obsession is, but we can't always figure out what the compulsion is. Now, I want to back up a bit and give you a slightly modified version of things related to compulsions. I want to talk about neutralization. Neutralization is a term that's a little broader than a compulsion. A neutralization is any voluntary, effortful, cognitive or behavioral act that's directed at removing, preventing, or attenuating the thought, that is the intrusive thought, or the associated discomfort. So compulsions are one overt type of neutralization, but there are other neutralizations that we see in almost every OCD case. So compulsions are one, reassurance seeking. Seeking reassurance from someone else that it's going to be okay if I touch the door, am I going to get sick? Some reassurance from other people about this connection. And avoidance behavior. Most cases of OCD not only have compulsions, but avoidance behavior. Avoiding those triggers that set off an intrusive thought. Okay? So the function of neutralization is anxiety reduction, to reduce the probability of a feared outcome, to decrease perceived responsibility for preventing harm, because one of the features of OCD that is powerful is this notion that the person feels a sense of responsibility for producing some kind of harm, either to myself or to someone else, and that over responsibility is a key piece in the way in which the intrusive thought is interpreted. Or to achieve a sense of just right. So these are the ways in which neutralization functions in this relationship between obsessions and compulsions. The problem is that neutralizations, including compulsions, are only provide temporary relief. So what happens is that an individual, and let me see if I can draw this out, if I can find some. You would think on a college campus there would be a piece of chalk near the chalkboard. So if you think about the way in which this happens and the experience of anxiety the person has when they are experiencing an intrusive thought, we can think of this on a timeline. So this is time, and this is anxiety. So if I have OCD and I have an intrusive thought at time 1, what happens is my anxiety goes way up. And my anxiety is up here until I engage in some kind of neutralizing strategy. And then my anxiety starts to come down. But what happens with OCD is that anxiety comes down until I have another thought, a repeat of that thought, or something like it at time 2, and then my anxiety goes back up until I neutralize and my anxiety comes down. And then when the thought comes back, my anxiety goes back up. So the graph of my anxiety looks like this, but it never really comes down all the way. Okay? And what we find when we do exposure treatments is that if we prevent this neutralization from happening, so if the person does not engage in the compulsion of the neutralization, the anxiety will stay up here for a while, but eventually it will come down like this. Okay? So that's the way in which the process, the relationship between the obsession and the compulsion is a key part of the process of what maintains the OCD. Okay? If we get rid of the compulsion, the OCD will go away. All right? It's because of the relationship between these two things. The other parts of the DSM criteria, the content of the obsession compulsion is not restricted to other disorders. So there is some relationship between eating disorders and OCD. Sometimes eating disorders look a little bit like OCD. But if eating is involved, and particularly body image is involved, then it's considered eating disorder rather than OCD. Trichotillomania, or hair pulling, is a comorbid sometimes with OCD, but it's not the same, and they're considered separate. Body dysmorphic disorder is very much like OCD, much more so than these other disorders, where the intrusive thought has more to do with appearance. But there are some differences in body dysmorphic disorder with OCD and other scores that leave it in a separate category. Substance use, hypochondriasis, paraphilias, guilty ruminations in major depressive disorder, these are all ruled out. Now, sometimes we see, sometimes people with OCD sometimes get into some kind of problems because sometimes the intrusive thoughts are about unacceptable sexual behavior. Often unacceptable sexual behavior means I had a thought about what if I had sex with a child, okay? And the problem is, if that's the intrusive thought in OCD, how do you talk to anybody about that? Because once you say something about that to someone, the first thing they're going to think is it's a paraphilia. That is some kind of sexual difficulty. So sometimes this distinction, you need someone who's familiar with OCD in order to evaluate these kinds of issues. There's also an insight specifier in OCD. So, and you specify if a person has poor insight. What that means is that for most of the time during the episode, the person does not recognize that the obsessions and compulsions are excessive or unreasonable. Most people who are diagnosed with OCD have pretty good insight. They recognize that this is excessive, that this is unreasonable. But there are some cases where that doesn't happen, and those cases require a little more than some of the cases where insight is not so important. So to understand the way this works a little more carefully, I want to go a little more detailed here. We try to evaluate, when we try to understand an OCD case, we look at 3 different things, okay? We start by looking at the trigger. What is it that triggers the intrusive thought? Okay, and that trigger can be outside the individual. So let's say that sitting on this table here is a knife. And I have the thought, what if I took that knife and I stabbed Ted? All right?
I know you have those thoughts. I don't.
intrusive thought is triggered by some kind of external stimulus. Okay? And that external stimulus then is something that will produce the intrusive thought and start this cascade of things that happen as a result of that intrusive thought. That the trigger might be inside the individual, in that might be in my head, I just have the thought of stabbing Ted or doing something like that. And then that will set off an intrusive thought. Often they take the form of what if I did that, okay? And then what happens is that it becomes a thought, an image, an urge, or it could be a sensory experience and not just right experience. That it doesn't quite feel right, that if I walk through the door, okay, and my shoulders are not equal distance from each of the door jambs, it doesn't feel right. So I've got to come back in, I've got to go back out again until it feels right. My walking out the door feels right. Okay, some people think that what's happening here is that this portion of the brain that's responsible for matching our experience with our expectancy is disturbed somehow. And so we have this sense that there's something wrong, that we haven't experienced something just right, and we have to figure out what that is, and that's why we go back and do it again and again. So the trigger occurs, that trigger produces the intrusive thought, and then what happens is neutralization. And the neutralization takes these different forms. First of all, avoidance behavior. So what do I do if this knife triggers me? I hide all the knives in my house. Or I don't ever invite Ted over to my house. But I do something to try to avoid the trigger so that I don't experience that intrusive thought. Or I might engage in a ritual or a compulsion somehow, where what I do if there's a knife is that I put my hands in my back pocket and I leave them there. One of the cases that we discussed in one of the classes is a fellow who has an intrusive thought of, what if I confessed to a crime that I didn't commit? And the whole cascade of things followed. And one of his compulsive behaviors to try to stop that was he put water in his mouth and held water in his mouth for hours at a time to prevent himself from confessing. And what happened then is his teeth started to rot. So this behavior, these rituals can be varied. There's almost no limit to the nature of the behavior that can be evolved as a neutralizing strategy to try to neutralize this intrusive thought. Mental compulsion, same way. Doing something in your head to try to block it. Often it involves counting. Sometimes it involves reciting a prayer again and again, and so things of that sort. So this sort of gives you a sense of what OCD is and how it sort of how it acts in each particular episode, and what we as therapists look for. We look for the trigger. We identify the intrusive thought. We identify the compulsions, and now we've got an understanding of the flow of this thing for this person. And then we start to figure out, well, what can we do to interrupt that flow? The prevalence for OCD, lifetime prevalence, about 2.5%. 2.5% of the population will have OCD at some point in their lifetime. The 1-year prevalence, that is the number of people who have this for any given year, is about 1.1 to 2%. The gender ratio is about 1.2 females to male, almost equal, but this is sort of an interesting difference between genders, is that for males, OCD starts earlier than females. So there's an earlier age of onset for boys who have OCD, and a slightly later age of onset for girls who have OCD. But by the time they get into their 20s, the prevalence rate's about the same for people with OCD. And there are no other demographic differences not related to socioeconomic status, not related to other kinds of things, and so forth. Okay. The onset, again, for males a little earlier, 14 to 19 years, females 20 to 22 years. The mode of onset is not really typical. For some people, it's acute. For some people, it's chronic. A half to 2/3 report some significant life event at the onset. So it really varies. Sometimes it can come on gradually, sometimes can come on very quickly. It's associated sometimes with the loss of a loved one, sometimes with a severe medical illness, sometimes a major financial problem, and for women, pregnancy. Now, there's also some indication that for men, pregnancy is also an onset. Not that the men are pregnant, but that the women they're associated with are pregnant. And so that also is not as much of an onset time for men as for women, but it is elevated compared to other time periods. Okay, so that's a quick rundown of OCD. It gives you a sense of what OCD is, how we look at it, how we try to understand the relationship between what's happening in the environment, the intrusive thought, the compulsive behavior, to give you a sense of what we're looking for and trying to understand this relationship. Treatment-seeking behaviors. Most OCD patients never seek treatment. And of those who do, most delay from 2 to 7 years after the onset of the disorder. A couple of reasons for that. One is just not wanting to admit this is a problem, not being sure what the problem is. A third is that there simply aren't enough therapists who know how to treat OCD to go around. That's changing somewhat. There are expanded efforts to train people to treat OCD. As some of you know, we've just opened an OCD clinic here through ServiceNet in town. We've trained a number of therapists in treating OCD. The International OCD Foundation has regular behavior therapy institutes where they're training people on how to treat OCD. So this is changing over time as we go along. Comorbidities. About half of people with OCD have another anxiety disorder. Most often social phobia, sometimes panic disorder, sometimes GAD or generalized anxiety disorder, which is a disorder associated with worry. And here is where we see people who have these intrusive thoughts about everyday life concerns, real life worries that sort of get focused on excessively. Depression, about a third of people with OCD have a depression diagnosis, either dysthymia or dysthymic disorder, which is a disorder where the depression is not as serious as a major depressive disorder, but it's also not as cyclical. So if the person's mood goes down, it kind of stays down like this. Major depressive disorder is up and down. It's episodic. So people go into a depression, they come out of the depression, go in and come out, so forth. Okay, so let me pause there for a minute and take any questions about OCD, because now I'm going to head into hoarding and talk about hoarding as a diagnostic entity. Yeah.
What percentage of the population was that? Was that the country or the world?
It's pretty standard throughout the world, the frequency of OCD. So this 1 to 2% is a prevalence rate that's observed in most of the prevalence studies that have been done in different parts of the world. So it's pretty standard. Yeah?
What are the triggers of more than one? Like, if there is a person who wants to do everything twice a day and who wants to do every little action twice or thrice, would that be OCD?
Say that again.
There was a single trigger that we talked about in the OCD. What are the triggers of more than one? Like, if every other thing triggers an interest?
Yes.
Like, for example, if a person in daily life wants to do everything twice or
Yeah,
thrice.
yeah. Most people with OCD have more than one trigger. So there are tons of things that trigger them. And the problem is that these triggers get associated with the intrusive thought. And then when you try to ignore the trigger, you frequently what people do is they'll try to distract themselves by thinking about something else. But then after a while, that other thing becomes a trigger because now it's associated with this. It's a little bit like, when I do this in my class, I ask people not to think about a white bear and to spend a minute not thinking about a white bear and raise their hand when they do it. And very few people can do it. And the ones who can do it, the way they do it is they start to think about something else to distract them. But then after a while, that other thing reminds you of the white bear. So it becomes a trigger. So that's that process. Yeah.
Can you speak to the SSRIs, the medications that people are typically prescribed for this?
Yes.
The efficacy and the place in
The SSRIs there are two forms of treatment that work, that we're very sure work. SSRIs and exposure response prevention. Now there are several variants of exposure response prevention. They work about at the same level, okay? But if you combine them, there's not a lot of evidence that combining them works better than just doing ERP alone, okay? It is better than doing just medication alone. So ERP is a little bit better than medication in terms of treatment outcomes. And when you combine them, you get better results. If you're on an SSRI, you get better results if you do ERP at the same time. If you're on ERP, not entirely clear that you get better results by adding medication. But most people who have OCD end up getting medication at some point. And that may be just because the treatments that are available to people. Yeah.
Did you refer to ACT?
ACT is a form of behavior therapy. It's like exposure and response prevention. It's called, the difference is it's still exposure-based, but it's focused on values. It's focused on reorienting your life to not engage in the compulsive behaviors that are kind of shaping your life. Okay, so it's focused less on doing exposures and more on living a life where you don't avoid those things that you avoid because of the intrusive thoughts. It's very close to exposure response prevention. Probably the active ingredients are pretty much the same because the person has to expose themselves to these things that are difficult, these intrusive thoughts. Yeah.
I'm sorry, this might be a bit of a trend, but I wonder, like, there are two types of responses. One is reflex responses, in which, like, for example, there is a hot water, if I touch it, I will draw my hand back. And the other is non-reflexive, which is like, if I cross by a red light, then I have to stop, and I learn it. So what kind of an association is this? I mean, how do the association come into being?
You mean how do they start?
Yeah. Reflex, or is it learned?
That's a topic for a different lecture. We do know quite a bit about it, and the way to think about this is that OCD is at its core a catastrophic reaction to an intrusive thought. Okay, that's the core of OCD. It's a catastrophic reaction to an intrusive thought. And what you're talking about is why is focused, what happens is, what is the nature of the interpretation of that intrusive thought? What is it the person believes is so important about that intrusive thought?
How can the association come into being? I mean, why does he associate with it? I mean, why does he associate the thought with the compulsion?
With the compulsion. Yeah, we do know some stuff about that, but it would take another hour or more. So, but we may come back to that later on in the lecture series. Yeah.
Is it still considered OCD if they act on that intrusive thought?
Yeah, it depends on the intrusive thought, but yeah, the intrusive thought might be, and so you have to make sure you're clear about what's the intrusive thought and what the behavior is designed to do. The behavior, the compulsion, the urge to do something, is an urge to do something to counteract the obsession. So if that's the core of OCD. So the thought, the urge to do something, has to be in response to an intrusive thought to kind of do something to stop the intrusive thought. Yeah.
Would an obsession with side effects from, let's say, psychiatric medication be an OCD, or would that fit under a different category?
Oh, that's a good question, and it may or it may not. It sort of depends on the way in which the thoughts are happening and the other beliefs associated with the thoughts. We see lots of people with OCD or have, and people who take these kinds of medications often have real serious concerns about taking them, side effects, what they mean, and so forth. It's possible that could be an intrusive thought, but it's not necessarily an intrusive thought. It depends on the individual case.
The fact that the slide would put up that, a lot of people tend to present like when they're pregnant or over the loss of a loved one or
Yeah.
a stressful event, does that imply it's learned and not necessarily you're born with it?
No, it doesn't. What we know about the origin of OCD, there is evidence that it's partly genetic. There is evidence that there are information processing parts of the brain that are operating differently. There are circuits in the brain that are operating with OCD that they're over-operating in OCD, and they're not when people don't have OCD. If we look at certain circuitry in the brain with someone with OCD, we see a level of activity that's pretty high. When they get treated, either with medication or with ERP, and we look at their brain again, then that circuit is slowed down. So we're starting to learn parts of the brain that are involved and how they're involved. But in truth, this probably involves some kind of combination of a genetic predisposition, some kind of environmental events that happen, and a general level of sympathetic nervous system arousal. That is, high levels of sympathetic nervous system arousal make conditioning more stronger. Okay, so it's easier to get conditioned to fear something when you've got a high sympathetic nervous system baseline level of sympathetic nervous system arousal. And one of the ideas about the way these things develop, the fears and so forth, is they may develop in part by classical conditioning. That is, there's an association with some kind of negative or traumatic event, and then the fear gets conditioned to that, and then they're maintained by operant conditioning, basically by avoidance. Because when we avoid something, like an intrusive thought or like a trigger for an intrusive thought, what happens is it strengthens the bond. And we are making the OCD stronger by hiding that knife. Okay? And that's the thing that maintains the OCD, is the avoidance behavior and the compulsion. Yeah?
Yeah, I'm a layman here, but I'm wondering, does OCD interact with criminal activity like kleptomania, that kind of stuff?
No, not OCD. In OCD, what you see here, and it sort of comes back to this question about where it comes from. The interpretation of the intrusive thoughts, one of the major interpretations of the intrusive thoughts, is an exaggerated sense of responsibility for not causing harm to other people. So it would be less likely for someone with OCD to engage in some behavior that clearly would harm other people. What we do see an elevation in things like kleptomania is with hoarding behavior. And here it's an uncontrollable kind of acquisition. It's not a huge association. A small percentage of people with hoarding disorder steal things. It's a little bit higher than it is for the normal population, but it's still not very much. Fewer than 10% of people with hoarding disorder actually steal things. Yeah.
So, I don't know how to word this, but is there something like if you getting over the behavior, like you almost start in recovery from your obsessive compulsive behavior, or is it like a cure? Is there like studies showing people have stopped lately, or?
So what you're asking is, what's the recovery like? I mean, how much do you recover? Yeah. There are people who completely get over their OCD. And here, I really encourage you to come and hear Shala, because her story is really dramatic. She was incapacitated by her OCD. Now it's basically gone. Now she does some prophylactic kinds of treatment things. Hers was a contamination fear. And so she continues doing exposures even though she has no symptoms now. Prophylactic means protecting against the symptoms coming back.
Okay, so almost like recovery, like
Working to keep the symptoms from coming back, yeah. But we do see people who completely get over it. Now, some people claim that doing ERP or cognitive behavior therapy can cure OCD. Is that true? I don't know, because we don't fully know why OCD happens. And until we know why, I don't know that we can really talk about a cure. But some people argue that with these treatments that we have, we can produce a cure.
To me, it would stand to reason that the more extreme, like the woman you're pointing to,
then it would almost be easier to get over because it would be so catastrophic. Whereas if you are less extreme, you tend to say, oh, you know, I can deal with it, I'm more functional. I mean,
Yeah.
there are obviously all
Yeah.
levels along the spectrum,
Yes.
but
Yeah.
I would think that there are plenty of OCD people
Yeah, who are functioning well enough.
well enough.
Yeah, and that speaks to,
It's obvious that the problem exists.
yeah, that speaks to the level of motivation for treatment. And the more motivated the person is for treatment, the better the outcome generally. That's generally true. Yeah.
I'm sorry for just like anything interesting from him. I had a question about, like, you said that it's, the people have an excessive sense of responsibility not to harm others.
Mhm.
So like for controlling their compulsions, the compulsions that they feel for, and that they feel to do that. In order to control that, if they hide their triggers and like hiding the knife, would they somehow be engaging in self-harm? Like feeling guilty for even thinking of harming others?
No, generally OCD isn't associated with self-harm. Those kinds of disorders are ones like borderline personality disorder. Those kinds of disorders are more likely to be self-harm. Sometimes eating disorders, not so much OCD.
What if a person is excessively, he's having excessive responsibility of protecting others and not harming others, and at the same time having an intrusive thought of harming others. So won't that lead to their personality disorder?
No, but that's sort of classic OCD, having this intrusive thought about harming others. It feeds into this sense of responsibility for not doing so. So because I'm having this, there must be something wrong with me. I've got to do something to stop this thought. And what I do to stop this thought is engage in some kind of neutralizing strategy, either hiding the triggers or engaging in compulsive behavior and so forth. Yeah.
If somebody is doing pretty well with OCD and starting to function much better, and then they have a traumatic event, like
Yep.
loss of a mother, what is your advice for them prevent them going backwards? Is it best not to confront their
Yeah.
files or things they need to work through and give themselves a break, or?
Yeah, great question. There's a lot of stuff just recently out on the treatment of OCD, because one of the issues that's come up for a while is when people get better following ERP. Sometimes it comes back, and sometimes it comes back quickly, especially if something happens, some kind of stressor. So there's been a lot of attention paid to, okay, how can we structure the ERP to make it less likely it's going to come back, and what do we do when it comes back? And the evidence suggests that what we do is at the end of treatment, when the symptoms have gone away, we help the person create the scenario to go back to doing the exposures if things come back. And that's what I was talking about earlier about prophylactic exposures. And that's the course. Usually when the symptoms come back like that, reinstituting the exercises done in exposure and response prevention will take care of it, and will go away again. Okay, yeah.
Does TMS work for OCD?
Good question. Does TMS work for OCD? At this time, we don't know. TMS is transmagnetic stimulation of the brain. It is a new procedure that has just been approved by the FDA for depression. It has not been approved by the FDA for OCD. All that exists right now are a couple of case studies on TMS and OCD. And in those studies, it looked like it helped a couple of individuals. But we can't, it's not something we would recommend because number one, it's expensive and we really don't know whether it works or not. In order for us to tell whether it works, we've got to have randomized control trials where we have a group of people with OCD who get TMS compared to people who get either a placebo or on a wait list to see if they do better. Until that time, it's not something that could be recommended for OCD. Okay, that was great. Great questions. Yeah.
So just in regards to the kleptomania part,
Yeah.
that he was talking about is the possibility of an event that somebody has with a friend that they haven't seen in a long time, and the friend used their pen to write something for them. And
Uh-huh.
so then they take that pen because that's an occasion or a reminder of that occasion. And then I think I could be going down a rabbit hole, but then it becomes, that folds over into hoarding because now you see them taking pens everywhere, even pens that don't work, or pens that have been run over by a car or something. Do you see that in terms of the kleptomania?
In terms of kleptomania, with hoarding, you might see that example where someone keeps the pen for a reminder of that particular time period. I'm not sure I followed the rest of it about collecting other pens, but it's not unusual for people with hoarding problems to collect large numbers of the same kind of object.
But thinking that it could start simply from that.
Yeah, the issue with starting is not, what's happened, most hoarding cases don't start acutely. Most hoarding cases start very young, interestingly enough. The symptoms begin between ages 15 and 20 and 25, but they don't get serious for decades. So we do occasionally see people whose hoarding behavior begins a little bit later, but generally not so much in that fashion. Sometimes they do, but not that often. So it's a disorder that is in some ways a little more insidious because it just keeps, it starts and it just keeps getting worse and worse. It's harder to treat than OCD. And the treatment is different than OCD, so we don't follow the same kinds of exposure paradigms, although sometimes they're similar. It's clear, and the questions have been great, but it's clear we're not going to get all the way through hoarding disorder this evening. So let me just make a few comments about it and then open it up for more questions, especially about hoarding if people have them. So hoarding disorder is new to the DSM. The primary criteria for hoarding disorder is this behavior: persistent difficulty discarding or parting with possessions regardless of their actual value. Now, when this diagnostic criteria was being put together, this piece of it was really crucial because in the DSM, the old version of the DSM, there was a disorder, one of the personality disorders, where hoarding was a symptom. And it was the obsessive compulsive personality disorder. The symptom was an inability to throw away worthless or worn out things. Now, what we know about hoarding is that it's persistent difficulty discarding and parting with possessions, but they're not limited to worthless or worn out things. People who hoard collect, yeah, they may collect things that other people think are worthless and worn out, but in truth, they collect everything. So people with hoarding problems collect virtually everything, things that have lots of value and things that have less value. And so this is in here to make it clear to clinicians that the actual value of the objects is really immaterial. Okay, it's difficulty parting with possessions. And the difficulty is due to perceived need to save the items and distress associated with discarding. Okay, so we do see occasionally cases where people's homes fill up with stuff because they're too depressed to get rid of it. That's not hoarding. Even though the house might look like a hoarding case, it's not a hoarding case because the origin is depression. There's no perceived need to save the item. Okay? The symptoms result in accumulation of possessions that congest and clutter active living areas of the home. Doesn't matter what your basement's like, your attic, even your storage shed. Okay? If your active living areas are not impaired and there's no other impairment, it's not hoarding. Sometimes the living areas are uncluttered because your spouse won't let you bring your stuff into the house, okay? In which case you might still get the diagnosis. And now, it's important to recognize this is the clutter criteria, but it's not a behavior. This is really unusual, isn't it? Because we're not talking about behavior here, we're talking about the consequences of a behavior. And yet, it's one of the diagnostic criteria. The hoarding causes clinically significant distress or impairment in social, occupational, or other important areas of functioning, including maintaining a safe environment for oneself and others. So we see examples of people who are either elderly themselves or living with an elderly relative, and the clutter puts that relative at risk. Or we see parents with children who are at risk because of the clutter. Sometimes children get removed for this reason. Okay, so that's the basic diagnostic criteria. There are a couple of specifiers. One is insight. The other specifier that I want to talk about before I stop, open up for questions, is with excessive acquisition. Now, based on the research that we've done, we know that somewhere in the neighborhood of 90% of people with hoarding problems acquire excessively. Okay? And the other 10% we think maybe are not telling us the truth. I think probably acquisition is as much a part of this problem as is difficulty discarding. And we see this excessive acquisition in a number of ways: excessive collecting or buying, collecting free things, compulsive buying, or stealing. Again, as I said, stealing is only in about 10% or fewer of 40 cases we see stealing behavior. So most of the behavior is with compulsive shopping, compulsive buying, or picking up free things. Sometimes free things on the road, sometimes dumpster diving, sometimes going in other people's trash, and so forth. So these are the diagnostic criteria. We won't have time to go into as much detail on hoarding, what we know about the way in which hoarding happens. But later on in the year, when we talk more about hoarding, we'll have a chance to do that. So let me stop there and open up for more questions. Yeah?
So I have some OCD behavior, and most times I'll show it to anybody else.
Yeah.
Only when I'm by myself. And when I get it to anybody, it's for an active stop. So I know what is that called, like exposure? That's kind of around me.
So say that again. What?
Exposure, like if I'm exposed or around people where I'm not performing my OCD
Yeah.
behavior.
Uh-huh.
Is that like exposure? So exposure treatment or?
It's not necessarily exposure, but in all likelihood, and again, there are probably more details to really figure this out, but in all likelihood, what happens is that there is enough other stuff going on in your mind when you're with other people that this intrusive thought is not prominent. Okay? It's when that intrusive thought is prominent, that's when the OCD comes out. And because there's so much else going on when you're with other people, that thought may not be prominent.
You know that even things, even if they don't have value, the value is, you're not necessarily saying financial value. The value is a self-designated.
For hoarding, yes.
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 So which do you mean that, like, you will keep it even if you yourself think it's worthless?
No, this diagnostic criteria is for the clinician. It's for the clinician to make a judgment about whether this thing has actual value to that person's life.
Oh.
Yeah.
I have a son who has OCD, and I've been thinking that he says he doesn't have a problem, and so doesn't want therapy, doesn't want medication. I've been thinking that, and I want you to tell me if I'm right in thinking this, I've been thinking that there'll be a time where he hits bottom, as alcoholics do, and his life will become uncomfortable enough that he will then say, yes, I need therapy, please help me. Is that an erroneous thought for me to have, or?
You know, that's a question I don't know if I know enough to answer it. It's possible that he will not get worse, that it will be the same. Most times, if nothing happens, the OCD tends to get worse, unless, and here's the thing, people can't get over it themselves if they engage in these behaviors that we do in treatment. So if he's doing things to expose himself to the things that he fears, it's likely the OCD will get better. And the first thing we do, this treatment is called exposure and response prevention. Response prevention is stopping the compulsion and just living with the obsession, the intrusive thought. And one way of doing that is to take a look at your life and say, okay, what am I missing out on that I'm not doing because of this? And I will just force myself to do that. I'm not going to get treatment. I'm going to force myself to do the things that I would be doing without this disorder. That's a form of response prevention that will produce exposures that will make his life better. So if he's not interested in treatment, maybe what you could do is talk with him about, well, what would you like your life to be like? And what about pursuing that? That may be enough to make the OCD get better.
Thank you.